All right. Hello, everyone. Welcome back. We hope you all had a fantastic holiday weekend and found some time to relax and recharge, and more importantly, spend some time with your loved ones. We're excited to welcome you to today's program where we'll dive into common challenges and new innovations surrounding organ transport. My name is Deanna Fenton, Program Manager here at the Alliance. And before we go ahead and get started, I'd like to just take a few minutes to review some brief housekeeping items with you all. Now, upon entering today's webinar, you may have noticed that all of your audio lines have been muted. This is to help us ensure that we have the best audio quality possible for our presenter and moderators. So with that in mind, we ask that you take note of the Q&A feature that's located at the bottom of your screen. This will be used to submit your questions to our presenter during the course of the presentation, as well as during our Q&A discussion. So if you have any questions that come up throughout the course of the presentation, please feel free to submit them there. Then once the presentation has concluded, we'll go ahead and transition into our Q&A discussion. We'll address as many of your questions as time allows. This is just to help you get an idea of where that Q&A button is located. Should you have any questions, feel free to reach out to us. You can always submit a comment or question in the chat, and we'll be sure to get back to you as soon as possible. Now, for anyone that may be interested in our upcoming webinars, we are very excited to announce that our very first few webinars of 2021 have been open for registration. Our first webinar is our donation-focused webinar, where we'll review the past year and what adapting to the COVID pandemic has taught us. You can be sure to join us for that on January 12th at 2 p.m. Eastern. Additionally, we've opened registration for our following webinar, which will be a transplant-focused webinar on telehealth and telemedicine and maximizing transplantation amid the pandemic. Be sure to join us for that on January 28th at 3 p.m. Eastern. Now, to stay up to date on all of our upcoming webinars, please be sure to visit our website at organdonationalliance.org. Now, following the conclusion of today's program, you are all eligible to claim continuing education credits. For this webinar, we are offering 1 CEP-C credit and 1 nursing contact hour. Additionally, for those of you who may be seeking CEs that are not being offered, there is a certificate of attendance that is available for you to claim as well. Prior to receiving your credits and certificates, you will be asked to complete a brief online evaluation that will allow you the opportunity to provide us with your valuable feedback. If you're listening in a group, please be sure to get the evaluation email from your group lead. As a friendly reminder, you'll have 30 calendar days to complete your evaluations and claim your credits and certificates. Now, without further ado, I'd like to go ahead and begin today's program by introducing both of our moderators. First up is Gina Dunn-Smith, Executive Director at IIAM. And we are also hopefully maybe joined by Dr. Nasrallah, who is a trauma surgeon out at Scripps. Unfortunately, he was experiencing some technical difficulties, so I don't know if he'll be able to join us today, but I'm happy to introduce Gina and welcome her to today's program. And without further ado, I'll go ahead and turn it over to her to introduce our presenter.
Thank you, Deanna. On behalf of Dr. Nasrallah, I wanted to let you know that he does send his regrets, and due to electrical outage at his home, he is unable to join us today. He did want to pass on that he and Dr. Scalea have their own history together, and Dr. Scalea was an intern when Dr. Nasrallah was a fellow, and he did share, that he had a prophecy that Dr. Scalea was not only going to be a fantastic surgeon, but also was going to be an outstanding artist. It looks like he has integrated the 2 skill sets to become a very dynamic innovator that you will learn about today. So I am honored to introduce today's speaker. Dr. Scalea is an associate professor of surgery at the University of Maryland School of Medicine, as well as a multi-organ transplant surgeon, researcher, and innovator. He attended medical school at the University of Maryland, and he studied transplant biology at Harvard University before completing his transplant surgery fellowship at the University of Wisconsin. Dr. Scalea is the director of the kidney pancreas transplant program at the University of Maryland, which he grew 200% to become the nation's largest SPK program in 2018. He received international notoriety in 2019 for pioneering the use of drones for organ transplant. He was Inventor of the Year in 2019 and the University of Maryland Entrepreneur of the Year in 2020. He has published more than 70 peer-reviewed papers with 10 successful grant applications. And most recently, Dr. Scalea became the CMO and co-founder of Baltimore-based medtech startups, MediGo and MissionGo, which aim to improve transplant care. He is a passionate surgeon and innovator who likes to paint when he is not operating. Dr. Scalea.
Thank you so much. And Gina, really warm introduction. Before I make any errors here, can I just confirm that you guys can see my slides? I've been guilty of showing my email while giving talks in the past. So very kind words. It is too bad Fadi is not on the line. He was indeed my fellow as an intern, and we have some wonderful experiences that I'm glad he's not on the line to share. But we do miss him. He's a wonderful person, human being, and dad as well as surgeon, and he is missed. Thank you to the Alliance, and thank you, Gina and Deanna, for the opportunity to speak today. I will apologize in advance for becoming impassioned and speaking quickly. I care very much about this topic. I care very much about transplantation. And I spend a lot of time thinking about how we can do what we already do better, which is where the innovation comes in. Today's talk is entitled Planes, Drones, and Automobiles. For those of you who might remember the movie Planes, Trains, and Automobiles from years back, with the subtitle, How Unmanned Aircraft Can Be a Solution to the Organ Transplant Challenges Facing or as a result of COVID-19. And I think you may already have a good idea of how that might look, but I'm going to walk you through a little bit of that history. I have some disclosures. I'm a passionate transplant surgeon. I care deeply about what I do. I love doing transplants and helping people overcome organ failure. Absolutely wonderful thing. I get paid for that, right? So I guess I'm supposed to tell you that. So the more transplants we do, I guess that's of benefit to me. I have research funding from a bunch of different folks, most recently of which appears to be the NIH. More to come on that soon, hopefully. I founded several companies, the first of which was TLI, which then transitioned into MissionGo and then split into MissionGo and MediGo. And those are, as described, Baltimore-based startup companies focusing on improving healthcare delivery in a number of different ways. In transplantation, we see this graph all the time, right? This is the disparity between the number of available organs and the people who need those organs. We have a woeful difference between the number of sick people in the United States and the number of organs. And while that's what we see all the time, the reality is actually a little bit more grim. More than 1 in 7 Americans, just looking at kidney failure alone, more than 1 in 7 Americans have kidney dysfunction, okay? And there are only 21,000 people a year getting a transplant. We have 90,000 listed, and the average wait list time is about 5 or 6 years to try to get all those folks listed. But there are 600,000 people on dialysis, 900,000 when you include those who've already been transplanted once, and 1.5 million who need a transplant. You don't need to go on dialysis in order to get sort of sick enough to get a transplant. Yet we're only doing 21,000 organs a year. And I don't want to scoff at that. That's with an enormous effort on the part of the field. But it's part of the reason that we're here today. There are ways that we can do what we're already doing better. There are different approaches that we can apply, innovative new approaches to help things grow. Taking you back to when I began at the University of Maryland, I was faced with this trend. I'm like this super eager beaver surgeon coming out of Wisconsin to the University of Maryland, where I was charged with growing the pancreas transplant program. And I'm like, yeah, it sounds totally great. And I get to the University of Maryland, and we see this, the same thing that everybody saw in the United States and worldwide, and that's that the total number of pancreas transplants are not going up, they're going down. So while the number of total kidney transplants have gone up as well as liver transplant, the number of pancreas transplants have gone down. And from 2004 to 2011, the number of SPKs dropped by 10% nationally. And the decreases in solitary pancreas transplantation were even more dramatic at 30 to 40%. And though I'm all excited to be a director of a program at a young age, you know, the reality is that the programs were failing, and that's very real. And why? The mortality of diabetes for people who are on dialysis is very high when compared with those people who don't have diabetes. So treatment with an SPK is an optimal therapy. And so I'm sort of sitting around thinking, why is this the case? Why are we having trouble getting patients access to this care? And why is that number going down? And I've given you a picture of a silo here because in many ways, surgeons in the context of pancreas transplantation became siloed over time. right? We weren't working as a collaborative team effort, combining lots and lots of different ideas from different spaces. And we're going to reference this concept several times today in order to try to identify the best therapy for patients. And so, whereas surgeons are sitting around saying, hey, I'm ready to do a pancreas transplant, endocrinologists are working on the next best insulin, and care delivery specialists are working on the best way to get folks care, and surgeons had become siloed. And so, using the data in the field where we knew that pancreas transplantation was associated with better long-term survival, better graft function, it's one of the safest operations that we do in transplantation. And knowing that we'd become siloed, I said, why don't we do something simple? Why don't we get, for this great big problem, why don't we get all a bunch of smart people in a room together and decide if this is something that we want to tackle? And if so, how we're going to do that. So again, being the eager beaver young surgeon and perhaps not being that smart, I got a whole bunch of smart people together in one room to help me solve the problem. And I said, listen, do we all understand that this is a really great therapy? Everybody said, oh yeah, that's a great therapy, totally. And everybody said, does everybody understand that the patients will live longer if we can treat their diabetes? They said, oh yeah, we totally understand. And I said, well, here are our volumes. Does everybody commit to the idea that this is something that we want to do? And everybody said, yes. Nephrologists, all right? Endocrinologists, transplant surgeons, hospital administrators, nurses, nursing assistants, right? Your role in the system doesn't differentiate your ability to help care for these patients. And when we did that, we took a very focused look at who we were going to help and how. And once we taught everyone how to identify where those patients and candidates were, as represented by the asterisk that you see on the screen here, the total number of pancreas evaluations began to go up. And it began to go up pretty dramatically to the point where we're now evaluating between 8 and 10 people a month at the University of Maryland for a pancreas transplant. Keep in mind, the international trend is that these cases are going down. And after we began evaluating patients, we transitioned that into real action. We started transplanting and a lot more. So much so that from 2015, where we'd only done about 11 transplants, we took that to 41, followed by 42 in 2018, becoming the busiest combined program, SPK program in the United States. The University of Wisconsin still biggest for total pancreas transplantation, of course. But the point here is that we were able to use a basic collaborative culture to drive a major change. We decided that what we wanted was better than what existed. We wanted to innovate that, and we were doing that through structure of the program. And despite doing more transplants, actually the outcomes didn't get worse, they got better. Okay, so we got volume and outcome at the same time with a thrombosis rate less than 2%, which is very low. You'll just have to trust me on that. And a 30-day patient survival of 99%. And these numbers hold true today. I'm very proud of our team for that. And as we began moving organs in, we're moving in organs from all over the place. Washington State, California to Baltimore. I start realizing, taking most of the primary call myself, that it's becoming more and more difficult to move organs. We're going to get to COVID in a minute, where it's been a 37% drop in commercial air travel. I think everybody already knows that, but that affects what we do. All right. But ill-timed commercial flights not designed to support transplant were getting in the way of our ability to save a human life with a combined kidney pancreas transplant. And I just thought to myself, I reject that. I reject that United Airlines availability gets to dictate if Mr. Smith or Miss Sally on our list gets a life-saving transplant. That's not okay. We just got to be something about how can the logistics of this problem affect the ability to save a human life? And not only that, but we know DSAs are changing. Cold ischemia times are going up. And that's partially because the distances over which organs travel are longer. Now, I'm not suggesting that allocation strategies are ill-informed. They're smart, and they're based on our ability to match immunologically a donor with a recipient. But we also need to commit as a group that we need to innovate the way that we're moving things, because we really need innovation in that sense. We need innovation. All right, and our enviable system of transplantation in the United States is among the best in the entire world, but it evolved, right? It wasn't designed to look like this. We didn't design it to say, oh, we're going to make cold ischemia time go up and the distance go further. We didn't say that. We said we want to get patients better matched organs, and we want to do as many as we can. But we along the way, we did not take the opportunity to innovate the structure and the infrastructure of organ shipment, which is what we're going to talk about today. And although we monitor every single aspect of the donor and the recipient from the time that the organs come out and the time the organs go in, there's this black box in between. And again, that evolved, it wasn't designed, and I know that we can do better. We throw around the term innovation a lot, right? That gets thrown around in healthcare now a fair bit. And a lot of centers have chief innovation officers and innovation programs. But what does that mean? Innovation has a definition. Definition's important, all right? And it's important for us to reflect on that briefly as we take a dive into what we've done here at the University of Maryland and now at Mission Go and Medigo, because it really helps sort of uncover and unlock what we think the future is going to look like. Innovative things need to be new, but not all new things are innovative. Okay, and so something that's new, I'm going to just give you a for example, like a jacket. Like you're going to buy a new jacket because it's getting cold outside. You can go get a new one. We can't go to a store anymore, but you used to be able to go to a store and get one. And you just get another jacket. It's new, all right? It's not an invention. It's not particularly unique in the context of the things that it's around. And it's certainly not necessarily better than the one next to it, but it's a new jacket. Well, now you have to invent something is a step further, all right? That's a little bit further down on the funnel that you see here on the right-hand part of the screen. You can have an invention that makes the jacket better or different, I should say, different. And just because it's different does not necessarily imply that it's better, but it's new and it's never been seen before. It's a creation of a product or an introduction of a process for the first time, maybe a new zipper or something along those lines. Now, innovation is when that technology is not only new and it's not only unique, but it is better than the prior technology which already exists. And that's important. Now, further yet is disruption, another important term, all right? And disruption implies that not only is that technology unique and is it better, but it's so much better that it's going to change the way that we think about the market. Something is so much cheaper, so much faster, so much better that we are really making a difference. Now, take those concepts and put them aside for a minute as we discuss the current shipment, the current system of organ shipment. Now, I'm talking to, I think, more than 100 people on this Alliance call who are intimately aware of how this process works. And you'll forgive me, you can see I'm an academician. I put together this slide myself, which is perhaps not very good. But you see it in the middle here in this purple box. This is an OPO, burning the midnight oil, sucking back on caffeine to try to get all these organs moved around and from one place to another. Now, the organs identify a donor, and once that donor is prepared and ready to go for the donation procedure, they try to find some ornery surgeon wherever they might be and send some transportation to pick that person up and bring them to some outlying facility hospital where they then arrange a courier to take the recovered organ that the surgeon was able to pick up to a tarmac where it goes to this guy and handing the organ box to some other person untrained. Now they're good at what they do, but that's not organ shipment, right? So untrained personnel on a tarmac to wait for a flight where it may then transition to another flight where it then gets picked up by some additional folks who, again, don't really know what they're moving in order to go to a second courier, if not third courier, to go to an OPO, to go on a pump and get a biopsy before it gets into the third courier to go to a blood bank in the hospital and eventually go into a patient. And it's incredible that we do that. We do that every day. You people on this phone call are moving mountains to do that. And it's incredible. That's the system that evolved. I submit that it's time to innovate that system and do it smarter. And not only is it challenging, but that complexity perhaps obviously comes with additional cost. So David Axelrod, very good friend of mine and really become a mentor from afar with regard to technology and innovation, David shared with me this slide wherein we can see that the difference in between local recovery, imported versus locally recovered organs comes at an enormous difference in cost, exceeding about $50,000 in 2020. It's a lot of money. Well, what if we did this? So I'm sitting around banging my head against the wall with trying to move pancreas transplants into the University of Maryland, struggling with the complexities of our system, which are inherently expensive. And I just say to myself, we've got to be able in 2020 and in 2025 and in 2030, we've got to be able to go directly from the donor hospital to the recipient hospital. Well, think about that. We could save time. We could save energy. It's certainly more green. We could probably be moving organs and not people, improving the safety profile of the whole process. So what if this doctor here picks up her cell phone and hits the easy button, at which point this beautiful device shows up and sends it to this guy over here, who then sews it into the patient in 5 hours instead of 15, or in 10 instead of 20, or at 8 a.m. instead of 2 a.m., improving the opportunity to have a seamless operation. So I'm starting to get excited about this. And I say, is this possible? Drones, like, really? Is that a thing that we should do? It's never been done before. And so I'm telling my wife about this. I tell her about all my crazy ideas. And she's like, yeah, I guess. I mean, maybe knock yourself out. So I call up at 5 o'clock in the afternoon. I'm a first year attending at the University of Maryland. I'm getting all excited because I always get excited. And I say, I pick up the phone. I call the aerospace engineering department. And I say, hey, I want to put an organ on a drone. And this guy says, wow, that sounds great. Let's talk. And this guy's name was Norman. We went through the whole process. I told him why I wanted to do it. And he said, I think that sounds absolutely fabulous. I think that's a really smart idea. And at the end of the call, I said, Norm, we didn't even really introduce myself. My name is Joe. I'm a transplant surgeon. I just started at Maryland. And he said, well, nice to meet you. I'm the chairman of aerospace engineering. and so with that, I had inadvertently on a Friday afternoon at 5 o'clock begun a very cool relationship with the aerospace engineering folks here at the University of Maryland, which has been a very fruitful relationship in many, many ways. And I began to learn about unmanned aerial vehicles, all right, UAVs, rapidly advancing technology. And you'll excuse the pixelated images here, but these are several examples of improving technology. These are even outdated here. They were perhaps very cool when I put them in here initially. These needs to be updated, but technological advances in this field have been dramatic, exponential. There are some aircraft which can stay in the air now for 13 days before refueling. Aircraft that can go more than 200 miles an hour. We have all electric options, making this far more green than 10,000 gallons of kerosene that we currently take to move 5 people in order to get a 10-pound box from a donor to a recipient hospital. And people are doing this in other capacities. AEDs, to defibrillate a heart for somebody who had a myocardial infarction in the field. That's been done in England, largely as a test, but it's been done. And so I think this is great. And so I'm all fired up. I'm like, we're going to save a bunch of lives. We're going to do something super cool. Nobody's ever done this before. And so I go to our Office of Technology Transfer, which is where you take an idea and they help you move that along and scale it so that it can actually be done for the public. They help you patent things and such and so forth. And they said I began to hear, I will leave all the names out, but that is crazy was one of them. Too big, definitely too hard. Lots of people said that. And too expensive. It will never happen is what I heard. And so I, of course, begged them for grant money. They, of course, said no for all the various reasons. And I said, well, that's fine. Can you guys give me like $25,000? So if somebody were to ever do this, we could at least know where the organ was with a tracking system designed specifically for organs. And they said, no, that sounds good. We're going to build a fancy box. We'll give you some money for that. And I said, great. So I took that money and, of course, I bought a drone, which is what you see here. So I also built built out the technology around organ tracking, which you're going to hear about more as we move on. So we began our first experiments with innovative shipment in 2018, formally. This was in February and March, as I recall. You can see some snow on the ground in the background here. So we have an off-the-shelf drone here with 6 vertically mounted electric motors that spin at about 10,000 RPMs that brought this thing into the air with a human organ, an organ procured more than 900 miles from the University of Maryland. This has been published widely. And during that time, we used specific telemetry to understand exactly what environmental changes were affecting the organ as it moved. And that's going to become important as we discuss this later on. And that's me on the left there, but that in the background is the actual organ itself moving for the first time. There's a first trip an organ ever took on a drone. And we learned a lot. We learned a lot from that. Number one, it was possible. Number two, people in that space, bringing smart people together. If you remember the pancreas transplant analogy, smart people together to decide how this is going to work, began to say, this is a pretty good idea. This is doable. And when we began collecting data around the telemetry of the way that organs are shipped, organ drone versus otherwise, we started learning some pretty cool stuff. Turns out when you move an organ by standard aircraft, and in this particular slide, we have chartered an airplane and used telemetry from the organ that was shipped to compare that with what we saw in a drone. We found that there was huge changes in G-force experienced by organs that are moved by airplane during takeoff and landing. Look at those differences. Very different than a drone. Now, this doesn't tell you that this specific drone that we used is somehow better than an airplane or not, but there are major differences which are clearly currently unmeasured, all right, that are affecting the organs that are moved. And this is super important. We monitor everything about the donor until the time that the organ comes out. We monitor everything about the organ and the recipient from the moment that we reperfuse it. But not a lot's happening in the middle, not until now. So can this really be done? So we've done this with a deceased donor organ, and we shipped it, and we used telemetry, and we showed that it was safe. We moved the organ over 3 miles to simulate or model the shipment of actually moving an organ between 2 hospitals in a city. That's what we did. All right, so we did 2018. And so can this actually be put into clinical practice? Now I get to work with Charlie Alexander, who may very well be on this phone call, but Charlie Alexander is an absolutely fabulous individual. He runs the OPO, Living Legacy Foundation here in Baltimore, Maryland. He's a very good friend of mine. He's been a research collaborator on a number of harebrained ideas that I and my colleagues have had at the University of Maryland. And we said, concept, Charlie, is one thing, but reality is another. Do you support this? He said, absolutely. It was also the time that I began to meet other people interested in bringing this forward. People began reading what we were writing and saying, I think you're onto something here. I think that innovating the way that we move organs and that we treat them during that black box period from explant to implant is important. I began getting support from other OPOs beyond Living Legacy. NEDS with Alex Glazier, absolutely fantastic person who's been very instrumental in at a minimum encouraging the growth of this program and actually supporting it in other ways as well. LifeSource in Minnesota, and Joe Ferrara in Las Vegas, Susan Gunderson, of course, at LifeSource. These individuals have been mentors from afar as well, highly supportive of the concept. And it was at the same time that I got introduced to a local impact investor named Scott Plank. Scott Plank, you may know that name. Scott Plank helped found Under Armour with his brother Kevin Plank. They were very successful in founding Under Armour, and Scott has taken it upon himself to help better Baltimore and areas that require innovation. And he's done that by supporting entrepreneurs, in this case, like myself, and now the company that we've started together. And when we began asking Charlie, others, how are we going to do this? How could we actually implement this? I took a step back to 2016 and I said, this is like a pancreas transplant. We have a great idea. We got a great therapy, but I have no idea how to do this on my own. We need to get a lot of smart people together in a room. And so we did. We got lots and lots of smart people together in a room. And we said, if we were really going to do this, if we were going to really begin to use drones to move organs, what would that look like? This off-the-shelf thing is probably not a good solution. How could we do that? So we got together in a room, an incredible panel of people. We got together engineers, drone operators, pilots, retired Navy folks, the head of Baltimore Emergency Services, the head of Baltimore Fire, the chief of police, hospital administrators, CEOs, nursing administrators, OR staff, transplant coordinators, research assistants, and otherwise, in addition to transplant surgeons, including myself. And we said, do we all think this is a good idea? And everybody said, yeah, it's a really good idea. Let's do it. We said, well, if it's a good idea, how's that going to look? And we took all that data and all those ideas, parameters, and requirements, and we used them to build this, the first device solely built for the purpose of moving human organs. And that was done through a series of 3D printing custom builds, in addition to some off-the-shelf equipment that came together to form this here. Now you'll notice it's built in the University of Maryland colors. That is not by accident. And everybody asks what this protrusion here is that's all red. That is a parachute. We had a parachute on this device. And we used that device to move the first human organ that was transplantable. And so in April of 2019, these pictures taken from JAMA Surgery as well as Annals of Surgery, where these data were first published, beyond the lay press. We share with you here in this slide the telemetry data from the first ever shipment of a transplantable organ by drone. And what we were able to record here on the left panel is the ambient temperature, the external temperature, and then you see the temperature of the organ itself. And there's a beautiful curve down towards 0, just above freezing, where the organ's temperature was held. And this here in the middle is a screenshot taken from a video watching that temperature decrease. We now have a user interface on the boxes that move the organs when in this case moved by UAS. We have then over on the right side of the screen, I'll call your attention to this differences in vibration experienced by different modes of transportation, car versus drone. You'll see here there was no statistically significant difference, but there are measurable differences in those effects and environmental forces. We biopsied the kidney before and after that transplant. We found that there before and after before and after shipment, and there was shipment had no direct effect on the organ itself. We transplanted that organ successfully into a woman named Trina. Her name is out there in the public domain, so we can share that. The kidney worked immediately. She came off of dialysis right away, creatinine dropping from 9 to 6, making 3.6 liters of urine before she left the hospital. Creatinine's currently between 1 and 2, and she's doing fantastic. And so this is me in the OR after being up for about 4 days, putting this organ in with my friend Love, who I've worked with now for a very long time. And after that experience, we began generating and getting a lot of attention. Now, some of this was intentional. We sought attention for this particular event because we knew it had meaning and we wanted to draw some attention to some of the cool stuff that we were doing in the hopes that other people might think it was important. And they did. The world cares about what you are doing in organ transplantation. They care a lot. All right. So much so that these are the kinds of things that make it into New York Times, CNN. I mean, this is from Manila, Japan, all over the world, Brazil. 1 billion people were reached by the article and the event, indicating to me that this matters. People care and people want to support it. It is time to move forward. And since that time, we haven't stopped. We're doing a lot of additional work. What you see here is a picture taken in Nevada of one of our newest devices, now custom modified in order to move human organs by drone with additional highly complex methods of actually holding on to the organs. You see it's taken in this is a picture from our company, Mission Go, taken in the desert of Nevada. Absolutely beautiful country out there. And there are a lot of additional questions to answer. I referenced the environmental forces that affect organ shipment earlier. We began to notice those in 2018. And here's some of those data. You know, when you move an organ up in the air, the pressure goes down. All right. So when it goes up and then down, you see what you see over here on the left, the pressure goes down and then it goes up. And if you hover and you keep it up at altitude, the pressure goes down, it stays down until you come down. And so that's particularly interesting. And it's particularly interesting in the context of COVID. There are things about COVID that have affected organ shipment in ways that we couldn't have predicted before. UAS have the ability to reduce the need to touch organs, right? If people are not always with them, we may be able to have fewer people touch organs. There's a reduced need for teams and people to move. I'm going to share with you a story about that in just a minute, but not everybody wants outside hospital folks landing on their helipad, coming into their hospital, bringing with them whatever they have, and using their PPE, which can cost upwards of $400 a person per use, all right? Plus, there's a reduced reliance on commercial aircraft in a UAS environment, all right? So right now, there's a 30% to 50% decrease in commercial aircraft across the country, let alone charters, which can be equally difficult to find. And in so doing, it may, oh, I'm sorry, let me go back. It is the time to innovate shipment is more important than ever, and drones may be able to help us do that. Understanding immediate organ ETA and location and awareness around human interaction using important monitoring tools has never been done, but would allow us, and the tools that I described earlier, would allow us to improve shipment practice to make it more streamlined, to limit touching. UAS could be used for blood shipment, tissue shipment, all of that is true. And in the process of understanding how that might look, we've had ongoing research to help us understand exactly how environmental forces and other things do affect organs. Now, these data are as yet unpublished. I'll ask you not to share them. But what you see here on the right side of the screen is a heart beating in a mouse. Now, that's a control heart that was not affected before it went in. But when we vibrate those hearts, commensurate with the same amount of vibration experienced in an airplane before it's transplanted, look at the rate of survival that you can see here on the right side in the red curve. On the red curve, we see that vibrated hearts fail at 14 days maximum. Whereas if you have a control heart like the one seen here beating, that continues to go on beat and beat normally for a period of time as long as the mouse is immunosuppressed. This is, of course, a transplant across an MHC mismatch. That's pretty exciting data. And we said, well, if that's true, why are these organs failing? What are the environmental forces that we are measuring during shipment? The tools that we are using to monitor so we can reduce the amount of people that are handling the organ and improve the efficiency. When we monitor those organs that are being shipped, how are those forces affecting the outcome? Well, when you vibrate that heart, again, commensurate with the level of vibration seen in a commercial aircraft, you begin to see graft death, heart cell death, called apoptosis, leading to failure, like I showed you in that previous slide with the mouse. So if you look at the upper panel and lower panel here, in a control graft, that means one that wasn't vibrated, there's very little in this right-hand side, green and blue together, implicating cell death. Now, when we vibrate the heart and then we look at that again, we see that annexin 5, a good marker of graft apoptosis or cell death, begins to light up, all right? And that's important because it's highlighting that vibration may be contributing to some of the cell death that leads to graft failure. And what about H&E stain? These are some of the standard stains that we use in transplantation to help understand what's happening in blood vessels. Here we see that vibrated hearts demonstrate an increased amount of microvascular thrombi. And then we see that on a tunnel assay, which looks at some of the genetic markers, we again see evidence of apoptosis or organized cell death. What we are not yet monitoring during that time of between explant and implant, and a part of the process that needs to be innovated, is affecting the outcome of that organ, we think. And when you ask the transplant community, this is now accepted. It's actually, I'm sorry, it's in press. Shouldn't say accepted anymore. This is a wonderful paper written by a resident of ours, Tara Tallier, in a British Medical Journal. This just came out that 87% of the interviewed transplant community members, we interviewed 174 people who all take kidney transplant call, 174 of them interviewed, we found that 87% of those respondents felt that we needed more transparency in the communication system, and that they desired to understand when organs are going to arrive because the current system doesn't meet their needs. And so we took that data, again, back to the drawing board, and said, if we don't understand what's going on during this period of shipment, drone or otherwise, is there a better way that can we innovate that process? Can we innovate the shipment process to learn how to better move organs, especially in a COVID world where you may have fewer and fewer people touching the organs? And we said, yeah, there's got to be a way to do that. So working from the transplant world out, working with OPOs from all across the United States, interviewing ASTS leadership, including my friend Marwan Dixon Kaufman, David Axelrod, Andy Cameron, as well as donor families of organ donors, as well as business leaders, we began to build together a set of requirements, just like pancreas transplantation, just like the first organ shipment, to understand what it would look like if we were to innovate that system. And again, it's important in the context of COVID. We've already had 13 million cases in the United States, 286,000 deaths, big peak initially in terms of death, and you see that that's beginning to climb again. The highest ever was recently recorded. It was actually just yesterday. This is now out of date, but 2,300 as of November 25th. The fewer people who touch and come in contact with organ shipment practice, the more that we can reduce the risk to our healthcare workers in the transplant space. And there's significant healthcare pressure in the context of COVID. We've had reduced operative cases and a reduction in transplant surgery because we didn't really know how to operate in a COVID world when things started. That reduced transplant volume by 40%, increasing waitlist death. Just because we can't travel easily, and just because the commercial airlines have reduced their ability to move at a schedule that works for us, doesn't mean we can stop transplanting. What drove those initial decreases was lack of understanding around testing, lack of understanding around who's going to get sick and who's not, and is it safe? Does the donor have COVID? Do they not have COVID? What kind of test was used? And here are the data. There in transplant patients who get COVID immediately after transplantation. This is taken from the New England Journal of Medicine. A friend of mine, Dr. Eklund at Montefiore in New York City, when they were going through a very difficult time, they observed very high early mortality among kidney transplant recipients with COVID-19. And indeed, 3 weeks after transplantation, 28% mortality, folks. Let that set in. 28% mortality. All right. Between 1 in 3 and 1 in 4 people dying of mortality, dying of COVID if you've had a transplant. And that seemed to be related to T-cell depleting agents, which made us pause and say, are we supposed to do transplants or not? Should we use a different agent? Now compare that with 1 to 5% mortality for the general population, or 8 to 15% for folks that are older than 70. You are more likely to die of COVID after transplantation than you are if you are 70 with COVID. And so that's important. And that's critical. Why? It's critical because we can't travel. COVID is with us. And this is a direct quote from a friend of mine, Brandon Bruns, who directs a trauma surgery center here in the DC area. And he said he got a frantic call. I got a frantic call from him on the weekend. He said, are you really still flying out to get organs? He said, yeah, well, people are going to die. He's like, you can't come in our hospital. You can't wear our PPE. I mean, is the PPE that you have safe? Or have your practitioners been tested to fly into a hospital in New Jersey? Should we fly into a hospital in a hot spot to go get organs? There's no better time to begin innovating the practice of shipment and monitoring during shipment than there is in a COVID world. And I hope I'm making that clear. You know, and these are real concerns that real people are facing. And when we don't address them, people die on the wait list. There's an acute need in transplantation for touchless recovery, which is what I would like you to consider the more global theme here is. The hypothesis being that there's local recovery, seamless organ recovery logistics managed by an IT platform like the one I'm going to describe in a minute, unmanned shipment in a beautiful future world, followed by local transplant implantation, completely minimizing the total number of people involved in travel and touching the organ, reducing PPE needs, cost, cold ischemia time, chaos, energy, certainly safety profile and such and so forth. And what's that future? When we got all those people together and we interviewed all those different players in transplantation, many of whom were on the phone, we built out a platform and a whole system to help us manage organ transplantation logistics better, and we call that Medigo. And Medigo, again, this is a company derived and inspired by the technologies we developed around the first shipments by drone using telemetry devices. We identified that we can now connect the donor with the recipient practice, getting rid of that black box period between explant and implant, and optimizing that supply chain using a touchless system. And so Medigo integrates the entire system by bringing real-time both communication, bidirectional communication, and actionable data through telemetry and otherwise to OPOs, transplant centers, surgeons to try to reduce the chaos of the system. And the value here is striking. Right now, more than $2 billion, we think, are wasted on the travel agency and inefficiencies of our system that could be obviated by connecting everybody on a single platform, which again is what we've done and what we've published on. And that's important. And to do that comprehensively in the vision I've described requires not only this platform through which everyone can communicate in both a compliant fashion and a real-time fashion, but the ability to move things in an unmanned fashion. And that's what Mission Go is. Medigo is our company that is helping to connect everybody and put everybody on a single playing field to help scale the number of transplants nationwide using efficiency. Mission Go, on the other hand, is helping to move use unmanned aircraft to move life-critical payloads like human organs. And Mission Go, as you may have seen not very long ago, did the longest flight ever, following our 3-mile flight here in Baltimore. Mission Go then successfully carried out the longest flight ever, more than 10 miles over the desert in Las Vegas, as featured in a number of nice articles. But there's so much more to do, right? Scaling transplantation requires incredible thought it requires incredible dedication. And there are people trying to do that. Just as we're trying to use drones, we're building out IT platforms and unique communication strategies. Folks are working on 3D printed organs to decrease the reliance on deceased donor organs, bioartificial organs as a bridge or even potentially a destination therapy for kidneys, maybe even liver one day. Good friend of mine, Martine Rothblatt, she's the CEO of United Therapeutics, working on organ reperfusion systems, and done some beautiful work there to try to optimize cold ischemia time. To get all this work done, which we've described here, I think very quickly today, jumping into a number of different topics, has required hundreds and hundreds of people. The first shipment ever required more than 100 itself, as well as folks from the FDA, the FAA, certainly dean's offices, the hospital, and such and so forth. Special thank you to all the people listed here, especially Dr. Barth, good friend of mine now at the University of Chicago, as well as some of the other surgeons that I work with, in addition to OPO staff, including Matt Wadsworth, Joe Farrar, Alex Glazier, Susan Gunderson, Charlie Alexander, Howard Nathan, Larry at Gift of Life, as well as my partners, Scott Plank and Tony Pucciarella at Mission Go and Medigo. And so with that, I just want to thank you very much. Future's bright. Thank you for allowing me to share some of my ideas about the future of transplantation with you and how that might look in a COVID world and really a post-COVID world. And I'd be happy to take any additional questions that you might have.
Thank you, Dr. Scalea. We do have some questions that are coming in. I'm going to start with my own comment here. This was a fantastic and very, very enlightening presentation that you gave. Thank you. You've shown the proof of principle about the use of drones as an option to transport organs for transplantation. So why aren't we doing this? And basically, what is the biggest barrier to doing this sooner than later?
That's a great question, and one that I know that we've all talked about, and that's been brought up in lay and scientific press. And so we said, so we've got this organ, it needs to go from A to B. We've got a device, and we can monitor it and measure it and keep it safe. So why not? why are we doing it more? And the reason is severalfold, right? There are sort of 4 buckets that I look at as challenges. The first one is regulatory. The FAA is responsible for keeping all of us safe. And in order to do that, they need to help understand exactly where where drones are, when they're going to arrive, how fast they're going, who do they belong to? Are they spying on us? So the FAA's regulatory elements have a lot to do with this. Commercialization of drones has been going on with everyone from Honeywell to Boeing to GE. Everyone is interested in doing this. And so the regulatory component is big. Second is technological. Do we have the devices that can really do this, do it safely? And that's critical. And it's important for me to bring up here, not because everybody on this phone call is an engineer, but because we all in transplant need to be part, Gina, of this solution. We need to be at that table to raise our hand and say, we need to be counted. Here are our thoughts about why transplant needs to not evolve into this, but needs to design elements of its own future. We need to help define the way this is going to happen. What matters to us and how should that look? There are medical issues. What are the medical issues related to moving organs by drone, if any? Vibration, extrinsic forces, telemetry data needs to be used, I think, in the context of innovative transport to help us understand that it's certainly not worse than anything that we're doing now. If not, is it better? How is it better? And help me understand why drones are smart when they are. And then the final bucket is ethics, right? I mean, there are a lot of negative connotations to the use of drones. Certainly, some may think that the way that they're used in military circumstances are challenging. That may be a negative connotation for some folks. And the last thing that we want to do in transplantation is harm that important trust that exists between OPOs, donors, and surgical centers to make sure that this comes together. And so there are some sort of 4 buckets of challenges affecting our ability to really make this happen. Probably the first and most important of which is going to be working with the FAA to ensure safety to the public.
All right, thank you. We have a question from Nicole Wicker. What is the cost to transport this way?
So I mean, make sure this doesn't get taken out of context. This is a fun one to answer. So the first one was $1.5 million, right? So obviously that's not going to be sustainable. But Nicole, great, it's a great question. So now imagine this. Instead of moving a kerosene burning 12,000 pound aircraft, right, to move a 10-pound box, you're now using a battery powered aircraft to move it the same distance, burning no fuel. And so what's the cost? The cost is in the future expected to be dramatically lower, but the benefits exceed the finances alone, right? So this is green. It's safer. We just, gosh, I don't know if anybody's on the line from USC. In USC, they just crashed a helicopter on their helipad, almost killing the crew to move a heart. And I mean, this is what we're doing right now. And that needs to be innovated. And so there are costs, but what are the costs and which costs are we comparing? I expect this will be financially cheaper. I expect that it will be safer, and I expect that it will be no slower and likely faster because of the logistics.
All right, thank you. Another question. You addressed the weather being or having an effect on the success of the transplant related to vibration and temperature. But I'm curious, what are the other weather elements that would impact the drone from transporting, such as wind, rain, snow, ice?
Yeah, it's fascinating. It's actually a fascinating concept. And the reality is, and I'm gonna sound like a bozo for a second. A 747 that you fly to Hawaii is already sort of a drone, right? It can be flown completely unmanned, right? Without a pilot, but it is flown with a pilot to be safe, right? And so that goes through all sorts of weather. Alternatively, like your kid might have a tiny little drone they fly in the backyard, and that's going to get like knocked out of the sky with 5-mile-an-hour winds. The drone that we flew, or the UAS that we used, the UAV that we used to complete our first flight, could fly up. It had to be FAA approved, which of course it was. Had to or flew through wind gusts up to I think about 30 miles an hour. I might be getting that wrong, but it's in about that range. The point being that the device is really the device that you're using is really what's so important there. And so can these things fly in inclement weather? Absolutely. When and how will that happen? It will be dependent a little bit on the engineering of the device, but it's certainly possible. In terms of extrinsic forces and environmental forces, the ambient temperature needs to make sure we need to make sure that we're recording ambient temperature, and that more importantly, we're recording the temperature at the level of the organ. What is happening to the vibration of the organ? What's happening to the pressure of that organ, and does that affect the outcome? Those are all things that we're studying, that are under active investigation, and how that affects the long-term outcome of an organ right now is unknown. What's really interesting is if you look at some of the liver transplant literature coming out of Australia, a group down there did some brilliant work looking at the outcomes of a airplane shipped liver versus a non-airplane shipped liver. And when organs are shipped by airplane, and in their case, most of the rest were shipped by ground, the outcomes are worse. They're about 10% worse by mortality at 1 year, which is remarkably different. Something about the way that we move organs and the environment around them differs between the way that we ship them, and that's something that we hope to learn.
So for clarity, Dr. Scalea, for example, when you go up in a hot air balloon, everything has to be perfect. And so my question is, if in fact other elements impact your ability to use the drone, if it became a more routine mode of transportation, would the weather also have to be perfect to use the device?
Yeah, my long-winded answer the first time perhaps didn't say it succinctly enough. It just depends on the device that you're using. And so there are some drones that will absolutely make it through inclement weather, and there are others that will not.
Okay.
And so I think it depends a little bit on what you're doing and what the risk-benefit ratio is. And so I think that if I were to guess and speculate, which is super fun to do, I would say that in the beginning, I expect that we'll have relatively primitive devices that can get us short distances between cities and avoid traffic and avoid putting people on helicopters in situations where they don't need to be. That's what I think we'll do first. And I think in those cases where you can't use a drone for inclement weather, I think you drive it, right? I think that's what you do in the beginning. And I think as time progresses, the technology will as well, and we'll have advances to allow for more frequent drone use.
Thank you. We have a question from Angie Corsum. How many centers or OPOs would need to participate in this to make it fiscally more advantageous?
Great, Angie, thank you for the question. So, so two parts to that. Again, so in order to you can't get to innovative transportation without understanding where things are, when they're going to arrive, and how they're going to get there. And so the beauty of building out an IT platform on which everyone can plug in is that we will understand when and where and how when organs are going to arrive, how they should be shipped, and when they should be shipped. Okay. And so the first step is to get on that platform. And to do that, we have already started working with about 5 or 6 different OPOs around the country. We just signed a contract to get people plugged in on this platform, Medigo, the Medigo platform. That was Nevada Donor Network, followed by a Midwestern group is shortly to follow, and then some East Coast groups after that. If your OPO would like to get on that in order to begin get in on the process now, that's how you do it. Thereafter, we are also doing, as you saw in Vegas, we're getting ready to do another in the Midwest. We are beginning to do UAS assessments of different OPOs. And so how many do we need? We'd like to get a bunch more people signed up so we can learn what the best course of action is. We think that there's an enormous fiscal benefit to the use of technology in the organ shipment process. So I tell you, first is to sign up for Medigo, and then the second is to contact us at Mission Go about doing some demonstration flights. We're happy to get that up and running for your OPO. Happy to do it.
Thank you. Final question. With this device and so far, the evidence that you have shown, the longest being 10 miles, and congratulations with that. It sounds like that this is a fantastic opportunity for OPOs such as New York, where the local traffic in and of itself can certainly be a complication in getting time critical organs from A to B. What is the reality of this becoming a cross-regional transportation device, and how soon do you anticipate something like that being able to happen?
So great points. So yes, I think that New York's a great example. Boston's a great example. There's 9 hospitals there in a short area, but having lived in Boston, the traffic can be terrible. And DC, Baltimore, DC is terrible. So that I think is a great first step. Cross-regional transportation to follow that, I would expect it to be sort of spoke and wheel. So in the beginning, just sort of sort of using like a hub, and then eventually hub to hub, maybe with 50 miles, 90 miles, 100 miles. Certainly looking into that, actively working with all of the regulatory bodies to try to make that a reality. I tell you, I think in the next 5 years, you're going to be seeing some pretty incredible UAS use. Once these federal regulations, all of which have before COVID, all of which had timestamps on them to try to meet these important milestones. Once those milestones are met with the FAA, I think you're going to start to see some real activity. And this is the kind of project the FAA loves because we're saving lives, right? It's not just doing this for fun. And so there's real benefit to everyone in the organ transplant community rallying around these technologies. First with tracking and data science at Medigo, followed by the implementation of unmanned use with the Mission Go shipments to really get this up off the ground. I mean, opportunity to save lives, make things cheaper.
Thank you. Fantastic.
Well, thank you, Gina. I think that just about concludes our Q&A discussion. So on behalf of the Alliance, I just want to echo Gina's sentiments earlier and extend a sincere thanks to Dr. Scalea for such a fascinating presentation. I know I'm personally very excited to see what the future of donation and transplantation looks like as it pertains to something as critical as organ transport. So thank you for taking the time to join us today and provide your insights. And Gina, thank you for doing such a phenomenal job facilitating today's discussion. I appreciate both of you and your efforts in putting together today's presentation. And of course, I would like to extend a sincere thanks to Dr. Nasrallah as well. I know he wasn't able to join us, but he too played a critical role in helping us to coordinate today's program. So a huge thanks to him as well. And to our participants, we thank you for joining us and hope you found today's presentation to be just as valuable. And I guess at this point, we'll see you in 2021. Have a good one, everyone.
Thank you all.